Hello and welcome to Medaculus. Today's topic is iron deficiency anemia. Iron deficiency occurs as a result of long-term negative iron balance. The iron deficiency spectrum ranges from iron depletion to iron deficiency anemia. Iron deficiency anemia is defined as diminished red blood cell production due to low iron stores in the body. It is the most common cause of microcytic, hypochromic anemia, in which the two red cell indices, mean cell volume, MCV, and mean cell hemoglobin EMCH, are reduced and the blood film shows small, microcytic, and pale, hypochromic, red cells. The World Health Organization defines anemia as a hemoglobin HB level 2 standard deviations below the normal for age and sex. In men aged over 15 years, HB below 130 g/L. In non-pregnant women aged over 15 years, HB below 120 grams/L. In children aged 12 to 14 years, HB below 120 grams/L. In pregnant women, HB below 110 grams/L throughout pregnancy. An HB level of 110 grams/L or more appears adequate in the first trimester, and a level of 105 grams/L appears adequate in the second and third trimesters. Postpartum, below 100 grams/L. A serum ferritin level of less than 30 micrograms/L confirms iron deficiency. The cause of iron deficiency anemia is often multifactorial and can be broadly attributed to dietary deficiency. This is rarely a cause on its own in adults. It takes about 8 years for a healthy adult male to develop iron deficiency anemia due to a poor diet or malabsorption resulting in no iron intake. Malabsorption, for example, due to celiac disease, gastrectomy, or Helicobacter pylori infection. Other uncommon gastrointestinal causes include esophagitis, schistosomiasis or hookworm, and inflammatory bowel disease. Increased loss, chronic blood loss, especially from the uterus or gastrointestinal tract. In adult men and postmenopausal women, GI blood loss is the most common cause of iron deficiency anemia. It can be caused by aspirin or nonsteroidal anti-inflammatory drug use, colonic carcinoma, gastric carcinoma, benign gastric ulceration, and angiodysplasia. Menstruation is the most common cause of iron deficiency anemia in premenopausal women. Other gynecological causes include hemorrhage in childbirth. Increased requirement. Physiological iron requirements are 3 times higher in pregnancy than they are in menstruating women, with increasing demand as pregnancy advances. Other causes. These include blood donation, self-harm, hematuria, nosebleeds, and medication. The complications of iron deficiency anemia can include cognitive and behavioral impairment in children, especially attention deficits. Impaired muscular performance, endurance, and exercise capacity are reduced. Heart failure. High-output heart failure can occur in people with severe anemia, especially in those with a hemoglobin level of less than 50 grams/L. Adverse effects on immune status and morbidity from infection. Visual impairment due to retinal hemorrhage in very severe, rapid-onset cases. Iron deficiency anemia in pregnancy has been associated with a number of problems, including increased morbidity for the mother and infant and the possibility of lower birth weight. Preterm delivery. Increased risk of preterm delivery and perinatal mortality. Maternal postpartum fatigue, altered cognition, and depressive symptoms. This in turn may affect the woman's interactions with the infant. Infant iron deficiency in the first 3 months of life. History. Diagnosis of anemia caused by iron deficiency is made by taking a history, performing an examination, and through investigations. Take a detailed medical history and ask about symptoms of anemia. If the anemia is severe, ask about specific cardiac symptoms, for example angina, palpitations, and ankle swelling. Diet, to identify poor iron intake. Drug history, for example the use of aspirin, nonsteroidal anti-inflammatory drugs, selective serotonin reuptake inhibitors, clopidogrel, corticosteroids, and long-term proton pump inhibitors. A family history of iron deficiency anemia, which may indicate inherited disorders of iron absorption. bleeding disorders, and telangiectasia, colorectal carcinoma, hematological disorders, for example thalassemia, gastrointestinal disorders, resectional or bypass surgery of the GI tract including bariatric surgery, a history of overt bleeding, heavy bruising, blood loss during surgery, or blood donation, a history of recent illness that might suggest underlying gastrointestinal bleeding, menstrual history, pregnancy, or breastfeeding, travel history, increased risk of hookworm in travelers to the tropics, weight loss, exercise regime. Iron deficiency anemia is common in endurance athletes. Symptoms. Symptoms associated with iron deficiency anemia depend on how quickly the anemia develops. People with chronic, slow blood loss may be able to tolerate very low levels of hemoglobin, for example less than 70 grams/L, with few symptoms. Fatigue and mild dyspnea after exertion may be the only symptoms in otherwise healthy people with slow-onset anemia. Very common symptoms of anemia include dyspnea, fatigue, headache. Common symptoms of anemia include cognitive dysfunction, restless leg syndrome. Rare symptoms of anemia include dysphagia, in association with esophageal web which occurs in Patterson-Brown-Kelly or Plummer-Vinson syndromes. Hemodynamic instability, syncope. Other symptoms include dizziness or lightheadedness, weakness, dysgeusia, irritability, palpitations, pica, abnormal dietary cravings, for example for ice or dirt, pruritus, sore tongue, tinnitus, impairment of body temperature regulation in pregnant women. Serious symptoms such as worsening of pre-existing anginal pain, ankle edema, or dyspnea at rest are unlikely unless the hemoglobin level is less than 70 g/L, and this indicates additional heart or lung pathology. Angina may occur if there is pre-existing coronary artery disease. Symptoms of iron deficiency may occur without anemia. These symptoms include fatigue, lack of concentration, and irritability. Signs. Common or very common signs of iron deficiency include pallor. This may be observed even with mild anemia. Atrophic glossitis. Dry and rough skin, dry and damaged hair. Diffuse and moderate alopecia. Other signs of iron deficiency include angular chylosis, ulceration of the corners of the mouth, nail changes such as longitudinal ridging and koilonychia, spoon-shaped nails, worsening of pre-existing tachycardia, murmurs, cardiac enlargement, and heart failure may occur if anemia is severe, hemoglobin less than 70 g/L. There may be an absence of signs, even if the person has severe anemia. Investigations. For people with suspected iron deficiency anemia, arrange a full blood count, FBC. If results of the FBC show a low hemoglobin and low mean cell volume, MCV, check the ferritin level. Check the ferritin level in all people with an MCV less than 95 femtoliters. Consider checking ferritin levels for pregnant women, but be aware that results may be less reliable in pregnancy. If iron deficiency anemia is suspected despite serum ferritin results within an expected range, consider diagnostic trials of iron treatment. This should only be considered in premenopausal women with a history of menorrhagia or pregnant women if there is no suspicion of celiac disease. Note: a diagnostic trial of iron treatment should not be used for men and postmenopausal women. These people are at higher risk of occult gastrointestinal bleeding and malignancy, and further investigations should be arranged. Other red blood cell changes associated with iron deficiency include reduced mean cell HB, hypochromia, increased percentage of hypochromic red cells, anisocytosis, variation in the size of red blood cells, poikilocytosis, presence of irregularly shaped red blood cells. For pregnant women, a full blood count is routinely conducted in pregnancy. In pregnant women, anemia is defined as a HB below 110 g/L throughout pregnancy. An HB level of 110 g/L or more appears adequate in the first trimester, and a level of 105 g/L appears adequate in the second and third trimesters. Postpartum, an HB level of below 100 g/L indicates anemia. If a blood film is arranged, it may confirm the presence of microcytic, hypochromic red cells, and characteristic pencil cells. However, hypochromia may also occur in hemoglobinopathies, such as thalassemia. In pregnancy, a physiological reduction in Hb concentration occurs, which does not represent anemia. There is an increase in red cell mass and plasma volume. The plasma volume increases more than the red cell mass, leading to hemodilution and a fall in the hematocrit from 40% to 33% on average. Normal pregnancy is also associated with a slight increase in MCV by approximately 4 femtoliters, and for milder cases of iron deficiency, the MCV may not fall below the normal range. Interpreting ferritin levels. Serum ferritin level is the biochemical test that most reliably correlates with relative total body iron stores. Low levels indicate low iron stores, except in women who are in the second or third trimester of pregnancy. In all people, a serum ferritin level of less than 30 micrograms/L confirms a diagnosis of iron deficiency. Ferritin levels are increased independently of iron status in acute and chronic inflammatory conditions, malignant disease, and liver disease. Expert opinion varies as to the level of ferritin that is diagnostic of iron deficiency anemia in people with chronic inflammation. People with a ferritin concentration of 50 micrograms/L or higher could still be iron deficient. In chronic kidney disease and other inflammatory conditions, a cutoff of 100 micrograms/L has been advised, but also needs to be interpreted in addition to other iron studies. If inflammation is suspected to be spuriously affecting the ferritin result, other markers of inflammation, for example C-reactive protein, or measures of iron status, for example total iron binding capacity, need to be considered. Advice should be sought from hematology or clinical biochemistry if in doubt about the selection of further tests and interpretation of results. A serum ferritin concentration of greater than 100 micrograms/L may not rule out iron deficiency anemia, but a result greater than this level should be interpreted in addition to other iron studies. For people with no known inflammatory states, and in whom the ferritin level is indeterminate, 31 to 99 micrograms/L, further tests may be required to ascertain iron status. For pregnant women, serum ferritin level is considered to be a reliable indicator of iron deficiency in the first trimester, in the absence of infection or inflammation. However, in the second and third trimesters, it is of limited use, as serum ferritin levels fall independently of iron stores. In women with adequate iron stores at conception, the serum ferritin concentration initially rises, followed by a progressive fall by 32 weeks to about 50% of the pre-pregnancy levels. This is due to hemodilution and mobilization of iron. The levels increase again slightly in the third trimester. A serum ferritin concentration of less than 15 micrograms/L indicates iron depletion in all stages of pregnancy, and treatment should be considered when levels fall below 30 micrograms/L, as this indicates early iron depletion, which will continue to fall unless treated. Further investigations. For all people with iron deficiency anemia, screen for celiac disease using celiac serology, presence of anti-tissue transglutaminase antibodies. If positive, refer for further investigations. Test the urine for blood. Offer fecal immunochemical testing, FIT, to guide referral of suspected colorectal cancer in adults. Consider stool examination to detect parasites, if appropriate from the person's travel history. Differential diagnosis. The differential diagnosis of microcytic anemia includes thalassemia, for people with thalassemia trait, alpha or beta. The mean cell volume, MCV, and mean cell hemoglobin, MCH, concentration are all reduced and are very low for the degree of anemia. Sideroblastic anemias. Alcoholism can be a cause of reversible sideroblastic anemia. Hepatosplenomegaly is found in a third to a half of people with sideroblastic anemia and is not present in iron deficiency anemia. Anemia of chronic disease. On analysis of the full blood count, in 80% of cases, anemia of chronic disease is normocytic and normochromic. However, in 20% of cases, it can present as microcytic, hypochromic anemia like iron deficiency anemia. Lead poisoning. People may have a history of risk factors, such as occupational exposures, for example, exposure to lead paint. Thalassemia and sideroblastic anemia are both associated with an accumulation of iron. So test will show an increase in serum iron and ferritin and a low total iron binding capacity. Iron deficiency anemia treatment. Address any underlying causes that can be managed in primary care. For example, treat menorrhagia or stop nonsteroidal anti-inflammatory drugs, if possible. If dietary deficiency of iron is thought to be a contributory cause of iron deficiency anemia, advise the person to maintain an adequate balanced intake of iron-rich foods, for example, dark green vegetables, iron-fortified bread, meat, apricots, prunes, and raisins, and consider referral to a dietitian. Prescribe all people with iron deficiency anemia 1 tablet once daily of oral ferrous sulfate, ferrous fumarate, or ferrous gluconate. Continue treatment for 3 months after the iron deficiency is corrected to allow stores to be replenished. If this is not tolerated, reduce the dose to 1 tablet on alternate days, or consider alternative oral preparations. Consider parenteral iron if oral iron is contraindicated, ineffective, or not tolerated. Do not wait for investigations to be carried out before prescribing iron supplements. Monitor the person to ensure that there is an adequate response to iron treatment. Iron supplements. The aim of treatment is to restore hemoglobin levels and red cell indices to normal and to replenish iron stores. A dose of 65 mg elemental iron, ferrous sulfate 200 mg, once daily, on an empty stomach, is needed to treat iron deficiency anemia. Dose-related adverse effects, gastrointestinal disturbance, from taking an iron supplement are commonly experienced. For people with significant intolerance to oral iron replacement therapy options include alternate day dosing, oral ferric maltol, or parenteral iron preparations. Note: switching to an alternate oral iron salt is not supported by evidence. Preparations which are not recommended include modified release iron preparations, preparations that contain iron combined with folic acid, vitamin B12, and other nutrients. Advice. Advise people taking iron supplements that they may experience adverse effects, but these usually settle down with time. Stress the importance of compliance with treatment. If they do experience gastrointestinal adverse effects, discomfort may be minimized by taking the iron supplement with or after food, or reducing the dose to alternate days. If these measures fail, they should return to discuss other treatment options. Explain the monitoring requirements. Advise people, especially the parents of young children, about the safe storage of iron supplements, as accidental overdose can be fatal. Monitoring. Recheck hemoglobin levels, full blood count, within the first 4 weeks of iron supplement treatment to assess the person's response. The hemoglobin concentration should rise by about 20 g/L over 3 to 4 weeks. If there is a response, check the full blood count at 2 to 4 months to ensure that the hemoglobin level has returned to normal. Once hemoglobin concentration and red cell indices are normal, continue iron treatment for 3 months to aid replenishment of iron stores, and then stop. Then monitor the person's full blood count periodically, for example, at 3, 6, 12, and 24 months. If hemoglobin or red cell indices drop below normal, prescribe iron supplements. Further investigation is only necessary if hemoglobin or red cell indices cannot be maintained this way, or if there is any evidence of an active undiagnosed pathology, for example, ongoing weight loss or chronic unexplained diarrhea, persistently elevated inflammatory markers, and the persistence or recurrence of IDA. Consider an ongoing prophylactic dose in people who are at particular risk of iron deficiency anemia. Ongoing iron supplementation. An ongoing prophylactic dose of iron, 200 mg ferrous sulfate daily, may be beneficial in some people who have recurring anemia, such as in an elderly person, and further investigations are not indicated or appropriate. A diet which is unlikely to meet daily iron intake recommendations, for example, some plant-based diets. Malabsorption, for example, celiac disease, menorrhagia, hepatogastrectomy. Ongoing prophylaxis may also be beneficial for pregnant women, people undergoing hemodialysis. If there is inadequate response to initial iron treatment, assess compliance and whether the iron treatment is tolerated. If an oral iron supplement, usually ferrous sulfate, is not tolerated, address the adverse effects. Offer a laxative to people with constipation. Offer reassurance to people who have black stools. Recommend the person takes iron with or after meals. Reduce the dose frequency of the iron supplement to alternate days. Consider alternative oral preparations. If the person is still unable to tolerate oral iron supplements, seek specialist advice. Refer people for specialist assessment if there is a lack of response, that is, an increase of less than 20 G/L in the hemoglobin level, after 2 to 4 weeks. If the person has already had normal upper and lower gastrointestinal investigations for iron deficiency anemia and the anemia persists or recurs, consider testing for Helicobacter pylori and eradicate if present.